Hello, everyone, and welcome to our July home health Q&A session. And I wanted to first start about folks that are trying to get note takers and AI onto the session. We deny those because they're not 100% accurate, and many times we'll give regulations and information and it will erroneously transcribe, and we don't want that to happen to our attendees here. But you will get the recording of this, and you will also get any handouts that we have that maybe will give you some references that you can use to go forward to learn from it. Cindy, did you have anything else? Cindy Kraft is with me today, by the way. Cindy, did you have anything else to add on that?
No, I'm eager to get started.
Okay, here we go. Everybody ready? Let's rock and roll. Question number 1. Palmetto just released a document called Writing Therapy Goals. Any thoughts on that, Cindy?
I found it to be interesting because I found myself in many situations working with agencies trying to tell me that Palmetto has said that you have to have short and long-term goals. And we see that in many EMRs, it's being templated that way, that here's your short-term goals and your long-term goals. And Sherry, you know, it's been a thorn in my side for a long time when we see that short-term goals basically is just every long-term goal cut in half. And it's like, okay, is this really useful? So when this document came out, and it's pretty short, what I did notice is they went to actual reputable therapy resources for this. And I'm not saying anything mean about Palmetto for that. I think that sometimes what we see in LCDs and such leave me scratching my head saying, where did you get that from? That sounds an awful lot like outpatient. We don't even do that in the home setting. But this one came out, and I think it's a very good one. And specific to the issue of short and long-term goal, I want to read it verbatim because I think it's important that we do so. So they're talking about the by when. By when is the target date to achieve the goal? Goals should be short or long-term. A long-term goal is the outcome the patient is expected to achieve. Short-term goals are goals which lead to the accomplishment of the long-term goal. It is helpful but not required to label the goals with the words short and long, but the goals should be written in a manner where there are measurable time frames and indicate whether they are short or long. So the dates alone should be able to do it. There is no set time frame that defines short versus long. If both short-term goals and long-term goals are not applicable, the documentation should specify this and explain. So up until that last sentence, I think it's clarified many things that have caused issue. They're not required to have short and long-term goals, that they're not about taking every one of the long-term goals and chopping them in half, thinking we're appeasing some requirement. They really are what we've said at K&K for more than a decade. Those are the steps leading toward the ultimate goal. That last sentence, though, we just got to be careful. I want to read it again. If both short-term and long-term goals are not applicable, the documentation should explain this, specify this and explain. Well, if there was no need for short-term or long-term goals, then there would be no plan of care. We can't write a therapy plan of care or anybody's plan of care without some sort of goal statements. So I would imagine, Sherry, that last sentence, if we kind of get stuck there, the simplest way to look at it is that would be a circumstance, in my mind, of the evaluation only, the one-time visit, because realistically, I am not going to see this patient, but that could be a little bit tricky in some of the EMRs where the expectation is I got to put goals on that eval only anyway. And sometimes the goals I've seen there are kind of weird. They look more, oh gosh, I got to humor somebody, so I'm going to put a couple things in there and then claim I met them on the visit. What they're saying here is if I'm really in a situation where they don't need goals, I need to explain that I'm not writing any because I don't need to write any because we're not continuing care.
Exactly.
What do you think about it, Sherry?
I think that folks need to realize that your goals that you write are a living document, and they need to be adjusted, not just at the time points that are laid out by CMS, but also as that patient's goals change. Because many times we'll start, say we have a fresh stroke that comes home And we'll start with goals that we realize in a few weeks are unrealistic. So it's really our responsible to go back and change those goals so that it is kind of that you're showing CMS, you're showing any kind of auditor or surveyor that you're actually using that to make your pathway for this patient. So Sydney, do you want to talk a little bit about that as well?
Well, yes, because one thing I really would love to see the day where we stop putting patient will be independent with a home exercise program.
Yeah.
That is not. And if you look at the rest of the Palmetto document, they do a good job of framing out other elements than just the time frame issue. But independent with a home exercise program is not an aspirational goal for the patient. I mean, the exercise program is being developed as a means to an end. I think we could do better than that. And that's where I feel a lot of our goals over time can become more habit than patient specific. Or I've had people say, but I was told if we don't document about this on the goals, then we're not going to get paid. Palmetto didn't say there was magic words that got you paid or magic bad words that don't get you paid. I also think, to your point, Sherry, changing goals, changing things about our care plan based on the current presentation of the patient shows more clinical decision making and skill than writing extremely generic goals in some by the end of the cert period arbitrary cutoff point and thinking if we keep them broad enough, then as long as I land in there somewhere, I'm not going to have to go through the process of updating them, because I know in some of the EMRs and the process involved with updating a goal can feel like it's more work than it's worth. But when we're able to show that we changed course, they aren't doing as well as we expected, or they did better than we thought, and so we need to upgrade these. But things like least restrictive assistive device, community distances, household distances, these terms are not doing us any favors in terms of being objective or patient specific. So I always look at it and say, I'm not going to write goals so narrow that it's highly likely I'm going to have to change them all. But we want to really be thinking about those goals are part of speaking to why skilled care is warranted. Because I think this also shows up, Sherry, on the reassessment. When we have to go out there and do that reassessment, I see patient progressing toward goals. Now, most of us have stopped the towel well business, but patient progressing toward goals is not actually a summary. It doesn't say which goals, it doesn't say how's the progress. And we know the reassessment is asking us to take objective data and really explain why we think additional therapy is warranted. And a review of the goal statements is part of that process.
And we always say that you have to include the F word, the F as in Frank word, that you can use it for whatever word you want. And in every one of your goals should literally have a statement towards what function are you working on with that goal. And we have a couple questions that are coming in. So I want to remind folks that if you have any additional questions, please add them to the chat and we will get to them as we receive them and add them to our presentation today. So Cindy, did you have anything further on goals?
Well, based on what you just said, I want to read one other statement from the document. What is the activity the beneficiary will perform? The activity should be observable, repeatable, and have a definite beginning and end. Statements like, quote, the patient will get stronger, quote, the patient will show improvement, are poorly written. Yep. So they've read some therapy goals. But yeah, you can see where they're not saying if you wrote those exact words, you're going to get denied. But poorly written really means we could do a better job with these.
And we can tell in 2 seconds when we audit documentation that who is copying and pasting goals from some template in a couple of seconds. So that's not a bad idea for efficiency, as long as you're individualizing each of those when you put them into the document. But when you put the same 20 goals on every patient, that's something that can be easily picked up by an auditor. So
well, I think, Sherry, a quick tip, and it's a variation on things we've said in other circumstances, but I think it fits here. I think it would be interesting to take just the goal statements out of the last 5 evaluations that the therapist has done, and don't tell them anything else. Here are the goal statements, and these are the last, these are 5 evals you've done in the last week. Obviously, I wouldn't pull them from 6 months ago, but can I identify my patient by my goal statements? Because if it all looks the same, I would have no clue which patient this is. And I think it would also help in that side by side, Sherry, to recognize, oh, wait a minute, I am just repeating the same 5 things on every patient. It can be a very eye-opening experience because many of us just go, yeah, I know how to write goals. I write good goals and we haven't had any denials. So why are they talking about this? I think it's a good opportunity to revisit that goals and updating and changing those really help to bolster the issue of medical necessity.
And Cindy, that's not just a statement for therapists. That also would work with your nurses, your OT, your speech, everybody. And those are also therapists, but you should try this activity with all of your clinicians, not just your therapy clinicians, and see if they can identify who their patients are. That's a very interesting exercise. That gets me excited. Okay, so a question that was put into the chat. Just want to confirm regarding the face-to-face, does it have to come from the discharging facility? For example, a patient was hospitalized and transferred to the SNF rehab, and home care received documentation from both within the 90-day window.
You want to take that one, Sherry?
It has to come from the referring patient or referring physician that's going to be following that patient, i.e. their primary care, their surgeon, somebody that has an invested interest in it. And yes, you can use the hospital discharge statement and the skilled nursing discharge statement, as long as the progression that has been shown from one facility to the next is going to show up on the face-to-face. So for example, if a patient couldn't transfer because of a certain type of surgery while they were in the hospital, the face-to-face may say that they're bed-bound or chair-bound. That should not, if they've gone to skilled nursing and they've improved from that, then that statement should be updated to why that patient needs home health and why they need it then.
Sounds
Cindy,
good.
did you have anything to add?
I do not.
And also there's some freedoms around who the providers are that were in the last proposed rule that you can look into, and it shows you that it does not have to be the same physician that signs the plan of care, but it has to be the physician that knows the status of that patient before you guys get them. So there is some flexibility around that, but generally it's the most updated information on that patient on the face-to-face. Okay, our question number 2. The proposed rule for 2027 talks about palliative care. Is this an expansion of the benefits?
Oh, I would, expansion is not really the language we're seeing with that. And I think there's going to be much more discussion leading up during this comment period. But I will tell you, Sherry, looking at the discussion in the proposed rule and to some of the folks that I've listened in on their thoughts on it, it's giving me PTSD. It's making me think about maintenance therapy because that was another clarification that it is part of the Medicare benefit and not an expansion. But we know that part of the issue, and I think it's going to come into play with this, is it's all well and good. You're clarifying that palliative care is an approach we can use in home health. And I believe for those who are saying, oh, it is something new, we don't do palliative care here. I'll tell you the same thing I tell people about maintenance. You are doing maintenance in your agency. You are doing palliative care in your agency. There's just been a hesitancy around how to identify it, how to document it, what we're looking for to defend skill. And I think the biggest reason for both of why people haven't done it before is the risk of denial, of it being attributed as not requiring skill, leading it to a denial that then reinforces the idea we shouldn't be doing this because they don't pay for it. So what we're going to need, Sherry, is more than one comment to say, along with this, CMS needs to ensure that the intermediaries reviewing our stuff are all on the same page, because that is what's gone off the rails with Jimmo and the maintenance therapy issue. Is CMS got, and how long has it been now, Sherry? 13? No, 15 years.
It literally just celebrated 15 years.
That's true. 15 years ago, they successfully forced CMS to admit that they can't deny off of the lack of improvement. And I think that therapy got caught up in that right away because of the maintenance therapy. But if you think about it, palliative care is kind of the same thing. You're not really expecting them to improve. And so What's going to happen though is in that open comment period, we want to make sure that they understand that the claim reviewers, the documentation folks, the people doing TP&E and all the rest of it need to understand this as well, because we still see problems on the maintenance therapy side of people getting denied over lack of medical necessity. Although I think part of that lesson learned that I think will apply to palliative care is our documentation needs to speak to the why now, in terms of whatever skilled service I'm providing this individual. Why is that skilled service required? And what am I doing that is indispensable in this patient situation? I'm not expecting things to necessarily get better, but there is an absolute reason they need someone with my skill set to be there. Because when I work with agencies and they talk about denials they've seen for their maintenance, and you shouldn't have this happen because maintenance is covered, yeah, it is covered, but if the documentation is just kind of repetitive, it looks like you kind of go and just do the same thing or teach the same thing over and over and demonstrate the same thing over and over, you are running a risk of denial. So I think there's going to be more to come as this moves forward, Sherry. But I think those of you who have braved it with maintenance therapy are going to see some overlapping and repeated issues here. But I think it's a good thing. It's a good thing for them to acknowledge. It just also, that PTSD point is, I get frustrated that why does it take this long to then say, oh yeah, by the way, this is covered under the Medicare. Ugh. The reason people weren't doing it is because you let people deny us for it.
And I just want to say that we have this opportunity to ask them for certain codes and revenue codes that match palliative care that can also save us in the event that we're seeing somebody, they're not seeing any progress, but we're providing palliative care. If we document it and bill it as palliative care, then it should be routed to someone who understands palliative care to review. So I think that's what they did with maintenance about probably, 8 or 9 years ago. They gave codes for maintenance. I could see where there will need to be a set of codes, a set of revenue codes and a set of HCPCS for this activity. And in my personal experience, Cindy, I shared with you before we got on today, that gap between home health and hospice is something that they're recognizing is very important. And some of the hospices that are getting into trouble for live discharges may have been actually doing palliative care. And that's something that right now is being picked up by physicians groups and using their secondary providers to have more access to the physician. And that's a Part B service. So that's kind of how that's been getting handled. But that still doesn't address what the patient or the caregiver needs in the home during that time between home health and potentially hospice. So I think that that's good that they've recognized that there's a gap there and they want us to help to fill it, but they need to put some infrastructure in there for the billing and whatnot.
And I think the other piece of having a billing code, Sherry, is to help make it very clear the intent of these visits.
Yes.
And this is where another lesson learned is there have been times where an agency is providing maintenance therapy and they're documenting it very well, and everybody knows what they're doing and why they're doing it. And yet it gets denied because the maintenance specific billing code wasn't used. Yep. That last piece of the puzzle fell off. And the reason being cited for that is if you're providing maintenance and clearly you're focusing on stabilizing function, but you're billing the code that is tied to improvement, then the argument is, I'm not paying you because you billed it as going after improvement and you didn't achieve that. So yes, that's nitpicky, and I've seen people successfully appeal it, and yep, it was simply a billing error. We know that maintenance therapy is not paid differently or anything of that nature, but I think advocating for a way to identify the visit on the claim will help agencies internally monitor to make sure that this is being done appropriately. We'll give them good data about who's actually doing this, but I think it also helps in terms of when it's being reviewed that it's clearly identified to all involved what this is by virtue of a standardized code. So we know to apply the rules appropriately there, because my fear is without it, it could get a lot more difficult to track, a lot more difficult to explain. So I know we don't like more, work or things we have to do here, but I think part of it is going to be, yes, we need a way for all to see what this visit was designated as.
And this is a nice time for me to remind everybody to use your telehealth codes. when you're providing telehealth, when you're calling a patient and they need instructions on something that doesn't require a visit, it's really important that we use those telehealth codes so that they can see how much time we spend on the phone with patients providing care, providing advice, providing all the things. And yes, no, they are not paid for. There is no charge for that, but that's a way for them to track how it's been used. Telehealth has been extended for a decent amount of time, but I think it's super important that we use those telehealth codes as well.
And
With the time factor, that's important.
And speaking of super important, Sherry, I think, again, it's not the most exciting reading, but every agency needs to spend time looking at that proposed rule and providing comments in the comment period for things you like. Yeah, we don't always have to fill it with what we're mad about now. It can be, encouraging them that maybe it's palliative care and you're very happy to see that there. You may say, well, do I really have to? Yeah, I kind of look at it as, when people write reviews, they usually are the grumpy people that get on there, not the happy people. So we want to reinforce that if there's positive things in there you like, but I don't want to see it. And what I found interesting is normally when the rule drops, there's kind of this barrage of webinars you can go and have this explained, and they're pretty quick once the thing drops. This time there seems to be some delay, some more having to peel that onion. And I think it's really risky to say, well, wow, at least they're not threatening to gut our payment again. I mean, it's not the 8%, 6% conversation that tends to dominate it. That was minor. I think a lot of what we're going to have to look at and give them feedback on is all the discussion about enforcement, about enrollment, keeping people out of the program, what can happen to people. The one, just kind of in a cursory glance discussion of, potentially having payments suspended because your agency is in an area known for. I'm like, wait a minute, you're going to suspend my payment because my neighbor cheated? I mean, hold up. So I think we can all agree that there are bad actors in this space and something needs to be done. Recent legislation referred to them as fraudsters, Sherry, and I always just think that sounds like a 50s gangster. Yeah, I'm a fraudster. And I'm glad to see more discussion about cleaning out the benefit from those folks, but we want to make sure they do it in a way that doesn't harm good providers and doesn't just allow the sneaky ones to sneak better and other people to get caught in the mix. So I would encourage spending time with that particular section and really thinking about what do you like about it, what don't you like, and letting CMS know our thoughts. Because Sherry, you know the cycle. If we don't get comments or we get very few, they just take all that silence as agreement that we think everything that they're going to do is wonderful. Doubt that, but we want to make our voices heard.
Also, just a reminder, the comment period ends on 8/31 at 5 p.m. Eastern. And if you look at the final rule in the first group of information, it tells you how to make the payment. Here we go for question 3. I have some dogs barking in the background, just like home health. Okay, when I get feedback on my completed OASIS, there are times I do not agree with the change or recommendation. Should I challenge that or defer to the experts?
Wow, Sherry, did we now just decide it's a 3-hour session? Oh, yeah, I have thoughts, and I'm sure folks participating either in the live version today or listening to the recording also have some thoughts, because ever since OASIS started, and we've seen it reinforced, reworded a little bit, but the bottom line has always been the clinician has the final say. That person whose name and by extension their license and livelihood is going to be attached to that OASIS document needs to have the final say. But we have to be careful with that because I think that the review process, whether it's being done internally or outsourced, really requires a high degree of trust. And trust but verify. That the feedback that I'm being given by the person who's tasked with reviewing my work is consistently, and I would argue religiously, following the official guidance. Because if I, as the data collector, have developed that level of trust with the reviewer so that I know the feedback they give me is coming from the guidance, that I can look at it myself in the guidance and see exactly where that's coming from, that it's a teachable moment, that yes, I understand that I was incorrect and now I understand why, and so I will not keep repeating this mistake. That's how it should work. I think right now we have some flaws on the review side. Whether it is inconsistency in the review process, such that one reviewer is more aggressive, the other one lets more things slide, can cause confusion for the clinician, or we're giving feedback that is not clear, or implies that, if somebody is dysmic, they always need to be at least supervised while they're feeding or eating. Now we're doing a lot of coloring outside the lines, which undermines the review process credibility. And when I hear that, what this means is the clinician has the final say. They have to re-review everything. Like when I get that OASIS, I got to re-review it. And as AI is moving into the space, AI is also doing but the clinician has the final say. So now I've got to proofread all of this and make sure it's all right. That's a lot of responsibility. And I know I own that responsibility because my name and my license are attached to this. But the idea that my organization has designated experts or outsourced experts in this OASIS space, and you expect me as the clinician to be the gatekeeper as to whether or not those recommendations are accurate. Well, first of all, that means I need a high level of individual OASIS knowledge to be able to figure out if the recommendation I'm being given is accurate. And if I had that level of knowledge, I probably should see little to no errors anyway. But I think we got to be careful and periodically audit our internal folks and our outsourced providers to say, are we still all on the same page? What is this feedback looking like? Is that feedback, if it's in writing, is it indicating the guidance language and things to consider, or is it starting to go over the line and present itself in a way that's more, you must change it because the therapy evaluation said they were dysmic? No, I can consider that, and I should talk to the therapist potentially and find out what was going on. But to tell me I have to change it because another discipline wrote this down, it is, again, not what the guidance tells us to do for collaboration. So can the clinician refuse? Yes. Should they just blindly trust the expert? I would say no, but I understand exactly why they do it, Sherry. If I'm doing my best to take care of patients and deal with the documentation, and I filled out this OASIS and I turned it in, and the agency has told me they are paying somebody to review this that knows more about this than I do, is going to check it, why would I not want to just be able to agree and just accept it? Because it should be the right information. It should be following the guidance. I should not have to fight back against erroneous review information. So in its purest form, I totally get the clinician is responsible, and the clinician needs to have that knowledge to ensure that's being done correctly. But I think from an agency perspective, from a leadership perspective, you got to make sure that the expert in that space or the AI technology pretending to be an expert in that space is giving the right information with an eye toward decreasing errors going forward. Because this idea that, I keep getting it back and the direction isn't making sense, and I got to fight every time and say, no, don't change it. No, don't change it. And then I get labeled as the belligerent one who won't just agree with the expert change. Then we create risk. Then we have answers that are not correct, answers that don't follow the guidance, answers that potentially conflict with my own information. And I'm left holding the bag because my name's on it. So I think there's a trust level. And again, trust but verify that review process is supporting your clinician with the right information and not encouraging them to do other things.
And that's just a sample of what we do in our OASIS Club. And the 2.0 version has happened this year. It's not too late to sign up. One of the things that we wanted to do was have a space where folks who are OASIS geeks and OASIS experts have a chance to communicate with each other and be in a community. But it also gives you updates each quarter when the quarterly Q&As drop, so that you can stay in compliance with any answers that have come down on those quarterlies. And our next session for that, Cindy, is for the the second quarter quarterlies. What's the date on that?
August 4th at 1 p.m.
August 4th at 1 p.m. We've already had one other in May, and all of the recordings are available, and you can see the communication that's occurred between the club members back to the very beginning when we started back in, I think, March. So take the opportunity. If you see training out there, I have not seen a single quarterly training that's under $99. This one is $99 for the year. You get all 4 of the quarter trainings with this membership. So that's quite a value, and it is a great way to round out your knowledge. I know some of the folks that are on this today are members of the club, and if they have any comments, they can make them in the chat. If they're having a good time with it and they've been a member for a couple years, it'd be interesting for you to drop something in the chat. Let folks know how if it is a benefit to your agency. So the next question is just about those quarterlies. The Oasis quarterly Q&As dropped this week. Did anything jump out at you, Cindy?
Well, I'm kind of worried about them, actually. With all the discussion of the proposed rule, I think they kind of appeared and maybe didn't get the attention they deserve. I'm saying that because 2 of them, and it's not super long. We don't have, like 20 questions. I think there's 9, but 2 of them very clearly state that this supersedes the guidance manual, like effective immediately. And anytime we see them deliberately highlight that they answered a question and they know they did it in a way that changes the guidance, we have to pay attention to those. The one that struck me the most, Sherry, was about height and weight. And you would say, okay, seriously, that's a question that is crystal clear about you need to actually measure this stuff. You can't just take the word of it from the patient, because it would definitely be wrong. Don't believe me. Everybody should pull out their driver's license and see how accurate it is on there. But it has to be an actual measure. And I personally, quick sidebar, I like to use that taking of the weight as an example of insight into the patient's functional ability. If they were completely safe and able and mobility was not their problem, then taking weight should be pretty simple. They should be able to get up from wherever they're seated, get to wherever the scale's usually kept, get on the scale, read the scale, get back off the scale, come back to where they started and tell me what the weight is. That's typically not how this works. We end up hovering, we go get the scale for them, we bring all this over. So if it's a struggle to get up and we weigh them really fast because we don't want them letting go of their equipment, then that needs to be a tell for the rest of the functional assessment. But what happened here? The question was raised, what if the patient is shorter than the minimum height requirement for the question, or weighs more than the maximum weight that's detailed in the question? Because if they are that short or that heavy, and I put in dashes, then this affects risk adjustment. So yes, dashes are an acceptable response for this item, and I tend to see a lot of dashes when the clinician is like, I don't have a scale, they don't have a scale. Are you telling me if I didn't actually weigh them, I have to put dashes? Well, technically, if you did not weigh them as part of your assessment, you have to put dashes, and dashes do create problems with risk adjustment. But CMS's response now was that if they are below the minimum height, then put the minimum height number in there. Okay, so I believe it's 50 inches, Sherry. So if 50 inches is the minimum height, and I've got a teeny tiny little old person that's 4'1", then I'm putting in 50 inches. And if the patient is over, what I believe is 450 pounds, if they're bigger than that, I'm going to put the max weight in there, because that will allow at least those pieces to roll into risk adjustment. So this is not violating the whole, you need to measure it. You can't just take the hospital records or something else. And if you truly do not measure it, yes, I have to put dashes. But in those situations where the patient hits those criteria, we are no longer supposed to put dashes. We're supposed to put those numbers. But I think because there's such discussion about functional assessment and wounds and all of those other things, that this height and weight thing can get kind of lost in the shuffle. And As a reviewer, I'm seeing numbers in both. I'm in good faith, assuming that you actually measured it. But if you're not, and I'm putting a bunch of dashes, then we do need to remind clinicians that there are implications for risk adjustment. Now, I've also worked with agencies that the clinicians are extremely clear that they don't have a scale, that the agency does not provide scales, they don't have a scale, and a whole bunch of their patients don't have scales either. Sherry, I immediately skip past the OASIS piece for a minute and go, how are you dealing with patients that have cardiac issues at a minimum
Right.
if they don't have scales and you don't have one? Because haven't been out in the field in a while, but we tell all the heart failure patients still that if you're starting to see a change in this is an early indicator, and then you got to get on top of it because you don't want it to be a 10-pound gain. So I think this question being in the Q&A is a good reminder that we got to make sure we know what the question is. I bet you there's more than one person who did not know there was minimum height requirements and maximum weight requirements on this. But it's also good to check in about scale use. It's good to check in about, okay, if you really didn't do it, there needs to be a dash in here, and we got to talk about what's the roadblock. Because from a clinical perspective, we might need to revisit who's got scales, how are we handling this, what are the resources available, because there are patient care implications of not weighing them, particularly in certain populations. What are your thoughts on that, Sherry?
Well, I think that, providing those pieces of equipment for your staff are super important, and scales aren't nearly as expensive as they used to be. So I think it's super important that you have that ability to give those things to your staff so they have them to use. Cindy, my question, and I don't want to get too deep in this because I want to remind people that we have a club where this could be discussed for, in my opinion, ad nauseum when it comes to the OASIS. I'm much more of a coding person. Um, but having that equipment, and also, can we access the medical record within a certain time frame for those measurements, Cindy, or is that something that is not allowed per the OASIS guidance?
No, the only exception it gives us is that if in the last 30 days someone from your agency weighed them or took a height measure and documented it in your medical record. So if you think about it, why would I, if I'm admitting this person now, why would I have already seen them within the last 30 days and done a weight? There are those situations with patients that come back frequently, or there was a brief break in the care or whatever, but it's a pretty narrow exception. If I don't get them on a scale, then there's a lot of dashes. And I see some questions about the scale. Is there calibration issues with us using our own scales? There can be. There's also infection control issues of how these things are being taken in and out of more than one patient's home. All that would need to defer to agency policy and procedure related to it if we're using our own. I think sometimes, Sherry, well-meaning clinicians will be like, well, this agency didn't give me one, so I have one in my car as a backup. If we're taking it in and out of the house, at a minimum, we're going to be dealing with the infection control piece.
And it's a small expense. So the way you get around that is to provide the scale to the patient and just leave it with them. And you can also do that until the end of the cert period and then get that back, sanitize it, calibrate it, and move it to the next patient. But to be treating cardiac patients without a scale is extremely highly risky. And I would not recommend that at all. So you have to get a weight at some point in time. So sometimes leaving that equipment with the patient for that period of time and then removing it and moving it to the next patient is probably the better way to go. Okay.
But real quick though, Sherry, because if people that were listening caught it, I said there were 2 items that have this supersedes the guidance. I'm not going to tell you what the other one is because I want you to go look at the Q&As. I think sometimes we just go, I'll just go to something and they'll explain it to me. If that stuff is saying effective immediately, this is the new guidance, and I'm going to wait until somebody does a webinar about this in a month, we got a problem because that stuff becomes law the minute that thing is dropped. So we always need to think about who in our organization stays on top of this, especially when it's that kind of implement now thing. We need to make sure that staff are aware, reviewers are aware of anything that is significantly changed.
And I'm very interested in what the workaround for that you put erroneous information into the document versus the dashes. That's interesting to me on another level, that you're putting what you know to be erroneous information in those items.
Well, Sherry, it's kind of like, so I can fudge it with these parameter issues, but I can't take the patient's word for it, or I can't
Yeah.
take the reading from the hospital yesterday. So I think that there's a moment of, okay, it's not a routine occurrence. We have issues with the parameters. So, okay, we might be able to then help risk adjustment a little bit. I think the bigger challenge is when you say there's no exceptions, you have to do it. I think that more often than not is what's driving a bunch of dashes.
And I really wish that AI would concentrate on things that maybe you could scan the patient and get a height and weight. Those types of technological advances would be really interesting in the house, and interesting use of the AI technology that's out there. Okay, Cindy, this next question is probably one of my favorites that we've gotten in a while. It's a little bit extensive, but it's an interesting question, and it's an interesting insight into how clinicians are thinking. So are you ready?
Yep.
Okay, and here's a reminder as we get towards the end of this, that you have the chat that you can ask any questions and we'll try to address them right away. How do I respond to an agency who wants me to see a patient, do the PT eval, have patient sign agency consents, quote, get the med list, unquote, and just do an eval? Not start a care oasis, no nurse was ordered, and they pay the eval rate, not the start of care rate, and they don't answer who will do the start of care, generate the POC, and submit to Medicare. My signature or the nurse?
Yikes. Okay, so going off the information provided in the question, this appears to be a situation where this is a therapy-only admission, and the therapist is not actually doing the OASIS, that they are not having them touch it. And so it's do the evaluation. I love the quotes on get the med list, which must just mean write it down or put it in the computer, and get consent signed. Somebody has to be doing that OASIS, and most likely it's being done as a non-billable nursing visit. Because if there's no justification for nursing to go in, we know nursing can't just make one visit and be billable. So the agency is incurring the cost of sending somebody out to do it. Now, the fact they're not telling this individual who's doing it and where's the plan of care, I highly doubt that the signature of the therapist is the issue here, because I did not sign off on an OASIS. So you can't put my name on one. I doubt that's what's going on. I would definitely be pursuing further who is doing the rest of this. But I guess my bigger question is, why are you not doing a start of care yourself? There's nothing that stops the PT from doing it. And we've talked about this in other situations, Sherry, sometimes a long time, about why therapists should do their own admission. So I would definitely want more detail of who's doing it, but I would also reconsider offering that you just do your own. There's nothing regulatory stopping you from putting the OASIS in that mix and doing the full admit. And if you're doing a full admission, then I could see why they would pay a start a care rate. But if you're literally doing an evaluation and copying a med list and getting a couple signatures, I can see why they're not willing to pay that at a full start of care rate.
And the med list could be 4 and 5 pages. And so I can see why that could get frustrating, and therapists can review meds, guys. That's not something that they cannot do. It should be in their education. And if they have not received that education, it is really of a professional concern that they go get that education, because in home health, it's super important that all of the clinicians that go in the house know what the meds do, what they're for, and maybe even some side effects of what you could see in the patient for the safety of the patient and safety of the clinician. So I think that this is an old practice, and Cindy and I have been around since Methuselah wore short pants, and we lived through the therapists can't do starts, or therapists won't do starts, was more of the question, the answers that we found. And we just think that it's horribly inefficient to do the PT only, there, the nurse does the admission. And it takes away from your ability to collaborate if you're not going to tell the clinician who's doing it. So that's something that doesn't make any sense to me either, Cindy. I don't know if you thought about that angle of it.
Yeah, there's some missing piece in there.
Yeah.
But because I think again, who's making the plan of care then? I mean, I guess you're pulling some therapy things from the evaluation process, but I don't know what else is going in there. And I wouldn't think, I'm going to go out the boundaries of the question a little bit, Sherry. I wouldn't think that this is occurring with a paper-based documentation system. Yes,
No.
there are still a few places that have paper, but overwhelmingly, this is an electronic medical record issue. I would find it hard to believe that I could not go into my EMR and find out who admitted them, be able to see that OASIS document and see the plan of care. Because
Yes.
if I'm not able to see either one, and this is a therapy only, and the nurse did a one and done and has no intention of coming back, I am in charge of this patient and I need to know what was on there. So
Mhm.
I can imagine, and if it's somehow this therapist is locked out of seeing nursing documentation, Sherry, you remember when that used to happen? It
Oh, yeah.
was, you could only, this is great, we're going to put everything into the computer, but you can only see your stuff.
That's right.
What was the point of that? I already know
Yeah.
what my stuff is. I want to look at other people's stuff. So this might take just a little bit more digging in the EMR situation to look and see what's going on.
And it feels like a hesitancy to trust the therapist, and that's something that's going to cost you in the end, not just in time and efficiency, but also in money. I mean, you're paying somebody to do a visit that they're not getting paid for when you have the nurse go out. So
Well,
you're paying for the
sure.
travel, you're paying for all the things. What?
One other piece, if there was a next generation to this, I'd be curious if this is an agency therapist or a contracted therapist.
I'm wondering if that's a contracted therapist that's doing their work on paper and then
Yeah,
being put into the EMR.
Because sometimes agencies want to keep that buffer with respect to a contract therapist versus and one that the agency has hired themselves. But I understand that to a point, but we're talking about implications for patient care. If I don't know what that Start a Care OASIS said, then how am I going to be gearing my care plan toward trying to achieve improvement or stabilization in key functional areas? If I don't know what was on that plan of care for sure, then when I deliver visits, am I following suit with what you put on there, or am I potentially doing something that a state surveyor might take issue with? So that was the only other thing I could think of, Sherry, that might be causing they don't tell me and I don't know who. And it could also be why the agency is deciding to have nurses do the admits. My guess is they'd be their own employees, to keep that out of the hands of the contract. But
Yep.
I think there's some
But
discussion needs to be had to rectify this. Yeah.
Taking this question on face value, though, Cindy, if they were our colleagues or our friends, we would probably tell them to run from an agency that's doing this.
Well, I would say, yeah, I'd want to see it. And if it's a big state secret, I would be very concerned as
Yeah.
to what is actually going on if I can't be allowed to see this information about my patient.
100%. There's a lot of agencies that can use your services that won't be so secretive about some things. So
Correct.
that, to me, if it was a friend or a colleague, I would recommend that they probably take them out of the lineup, if you will, put them on the bench for a little while. You guys expect real talk out of us, and that's just real talk. If I had a friend or a colleague that was in this situation, I would tell them, yeah, that needs to be benched for a little while. Okay, so next question, and I put up the slide about maintenance therapy, because it is the 15th anniversary of GEMO, and we have been big champions of maintenance therapy and the nursing version of maintenance for years. We've written a book about Cindy and Dee Cornetti wrote a book about it. We've done innumerable educations, and we have a great set of short videos with great information on them, so that it keeps your clinician's attention. And believe it or not, the first video in the series is available for $7. $7. And that way you can see what the education looks like and how different it is from some of the other webinars. They're at the link now that they can actually be used in a seminar, in a lunch and learn. They're under 20 minutes, so you can have time to discuss each of them as you go through them. So I really highly recommend that you look at this product that we've had on for a long time, and something that we consider ourselves to be experts in. Okay, so the next question. Do M1740 and M1745 correlate? For example, number one, memory deficit is marked in M1740. Can M1740 be marked never? I see this a lot at my agency, and the clinicians argue that while the patient may display memory loss and require supervision, they don't consider it a disruptive behavior. So we'll mark never for 1745. But my understanding has always been that if something is marked as M1740, then M1745 cannot be never. Thank you.
Well, if we start with that last piece, the idea that if I put something in 1740, I can't use never in 1745 is not supported by the official guidance. They have not made a 100% link between the two. If anything, every time we get a new guidance manual update, it does reiterate that questions stand alone. That there is nothing in there that says if you put this, then this is always what you put in the other spot. I can see where there's an inclination and there should be consideration of the relationship between the two, but the example provided is a great one. And I think that as written, the information from the clinicians saying, yes, there is memory loss, but it has not reached the level of being a disruptive behavior, then you can have an answer of 1 in 1740 and never in 1745. I think the issue is with 1745, this is an escalation because not only could it be things in 1745 that are laid out in separate response items in 1740, 1745 can also be marked for things that have nothing to do with 1740. I may be in 1740 and none of the ones they listed applied, but we see that the guidance around 1745 refers to things like sundowning, getting lost in familiar places. These are things that have reached the point where the patient, you're concerned that the patient can do things that potentially injurious to themselves or to other people. So the fact that 1745 contains examples of things that aren't even captured in 1740 shows that they are actually disconnected. And I think it's important to keep them disconnected because it does then speak to varying degrees. Someone with a minor memory deficit, yes, should be noted in 1740. If we're now talking that they're wandering at night, the caregiver can't get any sleep, this person is behaving in a way that's creating significant risk, then in that situation, I want to be able to highlight we've reached the level of disruption, and that's why we use 1745 for that. So yes, Sherry, I could have just said, no, they were right. But I think it's a question, and I like when we get questions that aren't the functional items always, because I get concerned that we're so hyper vigilant on some things like dyspnea and the functional questions because this is payment, this is VBP, but the cognitive behavioral is equally as important in accurately representing what's going on with this patient. And because it's cognitive behavioral, Sherry, I'm going to throw in a bonus comment. People can do with it what they want. I am still seeing far too many in utilizing our OASIS knowledge assessment testing program of when I use scenarios about the patient refuses to participate in the BIMS, you can clearly understand this patient is saying, I am not going to answer those questions. And clinicians then saying, should this be administered, putting no, and then skipping the whole rest of the assessment. That is not the directions for this, especially when the person is clearly telling you, I am not going to participate. You cannot then choose no, which says the patient is not able to be understood. I fully understood what you said, but I got to make sure that I follow the correct response pattern that they give us in the manual of what to do in a situation where the patient refuses. We can't get answers from them. It tells us exactly how to answer, what to skip, and what to put for the total score. So I had to touch on that, Sherry, because we're years into it. And even our internal review team sees clinicians putting no on that first BIMS question. And clearly this patient does not have an issue with being understood. So I could understand them for the entire rest of the assessment, just not for the BIMS, or wait a minute, the Alzheimer's test, which it is not.
The Alzheimer's test. Yeah, I recently had some health issues and had to have a evaluation by the nurse, and I went face to face with apathy, Cindy. literally was not asked a single OASIS question. And when I queried them, because I told them kind of what I did for a living, I said, don't you have some OASIS questions to ask me? And I was told that I didn't need to be asked the Alzheimer's question. So I actually had a conversation with the nurse and made sure that I said the apathy is one of the things that is really can put a real hampering on whether that is accurate. We have a question that came in. Is there a requirement that the provider must add a statement on the POC why maintenance therapy or nursing is needed?
Yes, we need to be very clear we'll speak to maintenance therapy at this point, that this is what I intend to do and why I intend to do it. Because you can come out of the gate, do your evaluation and decide, yes, we're going to do maintenance from the very beginning. And clearly that would be in my narrative summary about what we're doing. But I could also start out on a restorative focus of care, see some meaningful gains, but now I want to pivot to a maintenance approach to care because I want to make sure that the plateau they've reached is stable, and that it's not going to backslide. When I make that differentiation, I do need to update my plan of care and my orders and my summary statement to show clear intent. So it's the best way and the most proactive way to make sure anybody looking at this is clear about why we're doing what we're doing. Because with kind of I just switched over to maintenance and it doesn't really look any different than the documentation before, can create denial risk.
Absolutely. Okay, so here's our last question. I put up the last slide so everybody could write down the date. Our next session will be September 17th from 1 to 2. Apparently September only has 4 Thursdays, so we took the second or third one. And so 1 o'clock Eastern, just as always, and register early and send in your questions. As you go along during the day, you have questions, you have discussions in your agency. That's one of the things that we want to address for you. So if you have any questions that come up between, send them in. Just indicate whether or not you want them on the next Q&A or if it's something that you need an answer to right away. Okay, last question.
Sherry, I want to back up. Because as you were saying that, I reread that last question and it was specific to, does the provider have to add a statement on the plan of care? Okay. As far as does the order from the physician have to call it maintenance therapy? No. I mean, I would argue that that decision is not made until the assessment is completed. Even if they put maintenance therapy, I could do my assessment and determine there is the potential for material improvement. Therefore, I'm going to come out of the gate with a restorative focus of care. Yeah, I'm going to update that, my plan of care and all that's going to go to the doctor, but I don't need the doctor to say up front, this is a referral for maintenance therapy, or they don't, please, it just says PTOT or speech. But no, they're not obligated to direct that this is what's going to be done. They will see that information on the plan of care once I've made that decision.
Right. It's not like a protocol issue with some of your joints and things like that.
Correct.
You're going to go and make those decisions on your evaluation. Okay, last question real quick, Cindy. Can we use a resumption of care occurring on day 54 and completed on day 56 as a recert OASIS?
Sherry, if you want to jump in, it is my understanding that is a no.
That's a no. It's over the 5 days. If you're starting in the day, if M90 is going to be the day of 54, then it's going to be you don't have the 5-day window that you have with your start of care. That's my only argument to this. Yeah. It would really stink, but you have to turn around and do the recert OASIS.
Yeah. I mean, I think they've been generous with respect to the last 5 days of the cert, that if the rock hits there, you can combine the two. Mm-hmm. But it's to my understanding, that decision has never been about the 90 date. That's been about the date of the resumption of care. That's so right. If anybody's got different resources on that, Sherry and I never claim we know everything. That's my understanding at the moment. If we find something different or someone has something different, we'll be happy to share that information with the group. But you're right, Sherry. It's annoying when we're that close to being able to do it and can't. But
it's very annoying. Yeah. But you do have great information that will inform your research. So that's you usually get a decent summary from the hospital when they come back. So that's also a good thing. thank you guys for your attention. Thank you for attending. We had a good almost 90 folks that were with us most of the time, and that was wonderful. Thank you for providing information in the chat, and we'll see you guys in September. And please be safe out there.